You said, is it you? No, no, it's starting to get warm. Or warm up, I should say. In 10 minutes it'll.
I know, I'll put my cup back on.
You put it back out again.
And at the top, just write RFC 201. And I want you to think about it, not a long time. I'm going to give you maybe 10 seconds.
Did you say 10 seconds?
10 seconds.
Okay, I just thought me.
I want you to write down up to 3 things in RSC 201, which is Practices and Procedures 1, that you need me to review or go over. Write them down. If you don't have anything, don't write anything, but at least 3 things, up to 3 things. You can go all the way back to the beginning. Anything you need me to review. And then under that, I want you to write RSC 211, Cardiopulmonary A and P, and do the same thing. Underline the RSC 201 and the 211 so I can see when I read the difference. So the first one is RSC 201 and the next one is 211. Up to 3 things. If you don't have anything, don't write anything, but at least you can write up to 3 things, and I want to see what the commonalities are among all of you anonymously. I don't care who you are, I just want to see. And then the third one would be this class, pharmacology. That's RSC 231.
What is this class number? I'm sorry.
Hmm?
The class number for pharm.
231.
Thank you so much.
So it's 201, Practice and Procedures 1, 211, A and P, and then 231, Pharmacology. I want them in that order. Okay, and when you're done, you can hold it up and I'll come get it. Okay. If we look, I want you to look up here, and I've got to change a few things because medication is, okay. Is that everybody? Medication is changing. For number 6, ipratropium bromide and albuterol, make sure when you do that card, you don't put Combivent, you put Respimat. I have it here. I don't know if you can see it, because Combivent is going off the market this December. So Combivent is in your book, but it's going to be gone. The new drug will be Respimat. It's still ipratropium bromide and albuterol, but they're taking Combivent off. However, you may have a few patients in the hospital who come with Combivent because they've been using it and their medication hasn't run out, but when they get a new prescription, it'll still be ipratropium bromide and albuterol, but the trade name will be Respimat. So I want you all to do Respimat, all right? Yes.
On this sheet that we have, it says Combivent Respimat.
Combivent is going away. You
Okay,
can cross
so-
it out.
so
I want
it's just-
Respimat.
I guess I thought that was one drug.
No, it's 2 drugs.
Could you,
Combivent is going away.
Is the dosing for like the NPI still the same?
It's going to be the same.
would you mind spelling it, just because the screen's down on Respimat?
R-E-S-P-I, Respi, and then MAT,
Okay, thank you so much.
M-A-T.
Thanks.
All right? So Combivent is going away as of next month. And then number 19, okay, now you disappeared. Okay, number 19 on here, I have nitrophenol sodium. It's going away. Till late, it's going away. No more. So change your number 19 to Toby for your drugs, because you won't be using it. It's going away. That's the only thing about these drugs. They've changed. A lot of them have really changed. Like in your text, you have metaproterenol sulfate. Very few people are using that anymore because Albupen is our wonder drug now, but nevertheless. Okay? So number 19 for your drug cards, I want you to change it from nidrochromyl to Toby. Toby is tobramycin. Sometime you will have an opportunity, particularly if you work with children. This is an aerosolized antibiotic used to treat Pseudomonas aeruginosus and cystic fibrosis patients. And so I want you to change 6. Make sure 6 is really the same, but don't use Combivent. Use Respimat as your trade name. And number 19, just eliminate what you see here and change it to Toby. Okay?
Yes.
And this is just to get you started. But remember, new drugs will be coming out, and you, your department, and you will have to keep abreast. Because some of these drugs you're learning didn't exist in the 80s and didn't exist in the 90s. Okay, any questions with this? Okay. So when you go to clinical, like I said, if you do have a few patients with Combivent, it won't be long. They just will be using their medication. And then the next prescription, if the physician decides to keep them on it, will be Respimat. All right. But it's still, the two generic drugs, they'll still be synergistic. Okay? All right. Doyle, this morning I thought about you. Did you get your T-bar back?
Yes.
Okay, because I was looking for it. I said, oh my
I forgot all
God, I
about
didn't give
it,
him your
too, and we
T-bar. But you got it back?
Yeah.
Okay. All right, I'd like to return this.
Oh, no, you're fine.
Okay. That's your T-bar. I want you to have your T-bar. Okay. This makes my nose run. I need an Alfred. Let's turn to page back to page 98. And on announcements as well as the emails, whatever I post on announcements, it comes up in your email. One thing that I failed to mention, but I did put it here, short-acting drugs are referred to as SABA, that's short-acting beta-2 agonist, and long-acting are referred to as LABA. That's what that is. So when you see SABA or LABA, you know that it's either short-acting beta-2 agonist, SABA, or long-acting beta-2 agonist. Oh, okay. Yeah. I didn't tell you that. And it's not in the text, but that's part of our lingo or part of our dialogue we use. Okay? I wanted to tell you that. And then I talked to Miss Pope. Well, I dearly love her. I talked to Miss Pope, and so here we go. For albuterol, you need to know the dosage in small volume nebulizer, which I know she gave to you guys in class yesterday in lab. And what did she give you as a dosage for small volume nebulizer for albuterol?
2.5.
She gave you what?
5 million.
2.5 mg. Wednesday lab, write it down. It's in the book right here, but I want to be consistent. 2.5 milligrams mg, and formulary is changed in the hospital. 4 to 6 puffs. Yeah. Yes.
In the book, they had there was a 0.5% solution, and then we had 2.5 milligrams, 0.63 milligrams, 1.25 milligrams.
Adult 2.5. 0.6 is for children.
Okay.
0.63. Yeah. And that's 4 to 6 puffs. That doesn't mean everybody will get 4 to 6 puffs. A physician can order 3 puffs.
You had some people doing in the 20s.
It depends. But this is just standardized. Yes.
Would that dosage of the 0.6 be different for the children since the...
Yes.
How much?
Yes.
How much is
I'm
it?
just doing adults.
Okay.
I just do adults once.
I just forgot to get this down.
Oh, thank you.
How do you measure puffs as far as small volume nebulizer?
That's MDI. MDI, puffs is MDI. Small volume nebulizer is liquid.
So when you said 4 to 6 puffs, you meant that?
MDI,
Oh,
yeah. MDI, yeah. MDI would be the puffs, and the liquid would be the 0.5 milliliters. Yes. Ooh, I'm glad you asked that question. Ooh, let me clarify. Okay, if you look on page 98, under albuterol, it says small volume nebulizer, 0.05 solution, right?
Right.
All right, 0.05 solutions. And then the 2.5 milligrams, that means if it comes in an MDI, or it can be 2.5 milligrams and it comes in a solution, but in a solution it would still be a half a milliliter. Okay? Puffs is 4 to 6, that would be the MDI. So whenever you see puffs, you know it's an MDI or a DPI. When you see a solution, milliliters, you know that's a small volume nebulizer. She wants you to know that. You cannot go to clinical without knowing that. I asked her, I had to humble myself, what do you want them to know? She wants you to know albuterol. She wants you to know the dosage. She does not want you going to clinical and not know the dosage. Everything else she said will come. I'm like, okay. A few more she gave me. The Monday lab went through the, I turned the heat up and now I'm beginning to feel bad. Wow. The Monday lab went through the MDI and DPI and how to deliver it and how to set it up and use the spacer?
Yes.
Okay, so the Wednesday lab will do it tomorrow. She's doing that. Okay. All right. Levalbuterol. Most of the time, if a patient is using levalbuterol, it will be the MDI, and it comes standardized to 45 milligrams per puff. And with the MDI, because it's a little stronger, it's just 2 puffs every 4 to 6 hours. 2 puffs. That's standardized. Everybody see that? Any questions with that? So highlight that in your text.
So there's 2 puffs every 4 to 6 hours?
Yes, sir. So go back to the albuterol. What's standard for the albuterol is the 2.5 milligrams. That's standard. However, it comes in 0.63, it comes in 1.25, and it comes in 2.5. 2.5 is standard for the adults. The 0.63 is standard for the children, for babies, for young, for, you know, pediatrics. But it really, really depends upon what the pharmacy for that particular hospital is ordering. It really does. But standard is at 2.5 milligrams. Yes.
Do we need to know the duration time for the acting?
Well, you need to know ultra short acting, and long acting, and what, as far as that is time. Okay, you mean, so did I answer?
How long does it actually last? Like to know if
How long the treatment will last,
Yeah.
or the drug will last in the body?
how long the drug will last in the body?
Yeah, because that falls into ultra short acting, and LABA.
Okay.
Yeah, yeah. You know, the LABAs will last up to 12 hours or sometime longer. Yes.
Ms. Miller?
And also, but let me tell you this, you can learn that, but it's also based on patient assessment as well. Just because the book says that a drug may last up to 12 hours, it depends upon the condition of the patient. And so that means if they're taking a drug that lasts for 12 hours, however, if they need the drug within, let's say, 8 hours, then maybe a decision needs to be made. Maybe they don't need a long-acting beta-2 agonist. Perhaps they may need a short-acting beta-2 agonist. Okay, so this is text, but everything we do is based on patient assessment.
Okay.
Okay, yes, sir.
And you said that, I think you may have said that rescue drugs are short-acting and ultra-short-acting?
Well, we don't really use the ultra short acting. They're used for racemic epinephrine. What did I tell you it's used for?
Bee stings?
Cardiac arrest.
Not racemic epinephrine. It's not used for bee stings. No, sir.
Cardiac.
Cardiac
Okay.
arrest. I
Right.
just asked about racemic epinephrine. That's not cardiac arrest. What is a racemic epinephrine used for? We administer it.
For children.
For children and what else?
And vasoconstriction? Or decrease?
Vasoconstriction for specifically, what did I tell you?
Up
Somebody's incubated.
Somebody's intubated and they're going to be extubated and they have hoarseness.
Right.
They have swelling, right? Laryngeal swelling. We give them that racemic epinephrine, the vasoconstriction, the alpha property, and it reduces, it draws out the swelling. That's racemic epinephrine. And then we give it to the children, right?
Yes.
Right.
For croup.
Croup.
Good. Epiglottitis. That's racemic epinephrine. And we do administer it. So you may be working in an area where you've extubated a patient and they've got some swelling going on, and so you'd recommend racemic epinephrine. Okay? And then if you work in pediatrics, you will give babies or children. I say babies. I shouldn't say babies. I don't mean the babies, newborns. But for children who have epiglottitis, which is called croup, you would give them racemic epinephrine. Right? Mm-hmm. All right. Now, any questions with that? Because I'm going to ask. Epinephrine. That's the cardiac arrest.
I found my notes.
That's the bee stings, Kyle.
Okay.
And Rachel has been so kind. She has brought a training device. This is an EpiPen. Who? Somebody you use?
No, it's for my son.
Oh, for her son. Her son uses, and so she's been so kind, and I'm going to pass it around. And even her son, he's as precious as he can be. I just loved him when I saw him. I fell in love with him. He looks just like his mom too, just like her. An EpiPen. I don't know how old children should be, but even I would probably say around 7 or 8, they should be educated and taught.
They told me 5.
5? Okay, 5. They should be taught how to use an EpiPen. So this is ultra short acting, but in this case, obviously, it would be for a bee sting or wasp or whatever is indicated to prevent anaphylactic shock. So I'm going to send it around so you can see. That's epinephrine. Okay, we don't administer epinephrine. We could, but we don't anymore because it has such a strong beta-1 effect in it. We don't use it for beta-2 anymore because we have all these synthetic drugs like albuterol and levalbuterol. Make sense?
Yes.
All right. So you know epi is administered for full-blown cardiac arrest, and it has 3 properties. Alpha, that will get the blood pressure going, along with our compressions. Beta-1, that will get the heart rate accelerated, hopefully, and the myocontractility force, right? And then beta-2, that will help us resuscitate the patient easier. And so you'll hear the physician say, administer an amp of epi. All right. And then the racemic epinephrine is 50% less potent than the epinephrine. And we use it for 2 reasons. 1, epiglottitis, known as croup, or when a patient is extubated and they have laryngeal spasms or their airway feels like it's closing. And you will actually administer it. That's ultra short acting. Now our SABAs is what we will administer via small volume nebulizer, or perhaps the patient may come in using albuterol MDI or using levalbuterol MDI. Okay? And what I want you to make note of, albuterol does not come in DPI. Albuterol does not come in a dry powder inhaler. It's only MDI. See on page 98? Don't get tripped up about that. There was a certification question, and everybody thought that the correct answer was albuterol, and I told them no, because albuterol doesn't come in DPI. So we got to pay attention to that. Yes.
What is the tab?
A tablet.
That was
Oral.
remember the thing we put in there yesterday?
What is
this?
Wasn't.
That was
Excuse me, Rachel. She asked me a question. Thank you. What are you referring to? If you say tab, I'm thinking of
Well, it says
Oral.
tab, 2 milligrams, 4 milligrams, 8 milligrams.
oral.
Okay.
Take a pill. Okay? All right. Thank you. All right. That's oral. When you see tablet, that means oral. All right. DPIs do not. DPIs also have tablets, but that's not referring to a DPI. That's oral. Yes.
And is that, it says MDI tab or syrup, but does that apply only to like Ventolin if you, or ProAir if you scan across? It says MDI.
Yes.
Acuneb, if you scan across, it says tablet.
Yes. The Acuneb only comes oral.
Okay, so that's what this is indicating, that
Yes.
ProAir is MDI
Right.
and...
And it has to be oral because they don't come in DPI. DPI has the little tablets that are crushed, but it has to be oral because none of that is DPI. Does that make sense? So when it says tablet, it means take a pill, oral.
So the DPI, that dry powder inhaler, is just what it says is, they just take a tablet, grind it.
DPI, yes.
Put a
It won't
propeller
say
on it.
tablet with DPI. It will just say DPI.
Yeah.
You know it has to have the little pill that needs to be crushed and inhaled.
Okay.
Okay? All right. Yes, ma'am.
Are there any short-acting DPIs?
No.
No.
No. And one side effect of DPIs, for some people, it makes them wheeze. And let me tell you this, if you have a scenario, or even if you have a patient, and you start them on a DPI, and they start coughing vigorously, or get short of breath, stop it. Because it's irritating their airways. DPIs are not for everybody. So a patient that has a hypersensitive or a very hypersensitive airway, and they can't use DPIs because it'll irritate their airways. Because remember, what we're doing, it's like inhaling, just as an analogy, inhaling talcum powder.
Yeah.
And some people, it will irritate the airway, right?
Uh-huh.
Okay, so if you have any scenario where you administer a DPI, particularly like, let's say, young people or teenagers, you got a 14-year-old and you want to, the doctor has ordered whatever in a DPI, and you instruct her and he follows your instructions thoroughly, but they take the DPI and they begin to cough vigorously, or they say, ooh, this makes me short of breath, stop it. They don't need it. That's the only thing about a DPI. It will irritate some people, and how do we know? We won't know until we try. Okay, so anytime a patient takes an MDI and they begin to cough, or they begin to say, I'm short of breath, or I can't handle this, just stop it. Just stop it. Okay. Another thing that I want to tell you, which doesn't have anything to do with pharmacology, anytime you're doing any respiratory care, like you're suctioning a patient or you administer a treatment, and a patient begins to cough up bright red blood, stop. Stop it. Do not proceed. Then you need to notify the physician. Don't finish. I don't care what it is. Don't do it if they're coughing up blood. And it doesn't mean you've done anything wrong. It means something's going on, and we need to assess. And whether we assess or a physician assess based on diagnosis, let the physician know the patient is coughing up bright red blood, some airway is bleeding, something's going on, stop it, okay? So back to the DPI. If a patient is taking a DPI and they followed your instructions, but it makes them cough or it makes them wheeze and it irritates their airway, stop it. That's not for them. And these are the kind of things when you take your boards, they ask. They're not going to ask you about dosages. Well, once in a while they'll give you a dose, but they don't ask about the dose. They want to know if you have a patient who's taking a DPI and they begin to cough vigorously, what are you going to do? Stop the treatment and notify the physician. Stop it. If you have a patient that begins to cough and you see bright red blood, stop. Something's going on. Does that make sense? Okay. All right.
They'll actually start coughing up that bright red blood.
Something's going on, and it may not be anything that you did, but you have to let the physician know. You got to stop right here and see what's going on. Now, if it's old blood, that's different, and that will correlate with a respective diagnosis. Does that make sense? All right. Old blood is different, but bright, fresh red blood, stop whatever you're doing. If you're suctioning a patient and you begin to get blood up, stop. See what's going on. Find out. You got to talk to somebody. And so the best answer is notify the physician. Okay, and the answer is never inform the nurse. Why? Because all the nurse is going to do is what?
Call the
Call the
doctor.
Call the
doctor.
physician. You can do that. Okay, so Ms. Pope wants you to know about the albuterol. And I want you to know that it comes in the small volume nebulizer, 2.5 milligrams, that's adults. The MDI, you don't have to know the milligrams, but generally about 2 puffs. And to be honest with you, not to say that you won't use it, but if you have pediatrics, it comes in a syrup. And then for some patients, I've never seen patients take it orally, a tablet. But it is prescribed that way. Okay. The long-acting, in the hospital, we will not administer long-acting beta agonists. We will not. But the patients may come in on long-acting beta-2 agonists. And they may go home on them. But doctors really don't like to keep patients on LABAs because remember, it's a sympathomimetic and it's stimulating the sympathetic nervous system. So we don't like to keep them on long. So if you had to make a recommendation, if a patient is on a LABA and maybe they're still wheezing or still in trouble, what might you recommend? Corticosteroid, absolutely. Corticosteroid. And that's for the anti-inflammatory process. Yes.
Now, you had mentioned that you have a problem with dust. At any point, do we ever
Have a problem with what?
like dust?
Oh, yeah, I do.
Yeah. Do you ever talk to patients about maybe, when's the last time you've gone through and had your vents cleaned? Like, at any point, do we ever discuss?
Asthma educators do that.
Okay.
And sometimes patients at Harper Hospital, they have an asthma clinic. They have a cystic fibrosis clinic, and they have another clinic. They have one more. I can't remember. But anyway, asthma educators will do that. Sometimes pulmonologists or primary care physicians will send patients to allergists. And in some offices, depending on how large the office is, respiratory therapists will work in that office, and so they will educate as well. Yeah. Once it's been determined what patients are allergic to, they will be educated either through a nurse or a respiratory therapist, but more than likely, if you are a home care respiratory therapist, that's where you can really emphasize information. Yeah. Okay, any questions about that? All right, I want to know, you're going to be able to tell me when to use epinephrine? Okay. And what 3 effects it has in it? I want to know when do we use racemic epinephrine, and the same 3 effects that's in epi is in racemic epinephrine, right? But we know it's 50% less potent. We need to know the dosage, adult dosage. I'm sticking with adults. Adult dosage for albuterol, for small volume nebulizer. Seems to be the wonder drug now. At one time it was metaproterenol sulfate, Algepint. Now it's albuterol. Okay. And know that it comes in an MDI. And I also want you to know that albuterol and levalbuterol does not come in DPI. It does not come in DPI. Yes.
For a drug card then, can we just eliminate anything that has to do with children or infants?
Nope.
Oh,
Cure surface for infants, absolutely not, no.
So we have to do then for, if there's information. for
Yes,
children, fine.
yes. Cure surface just for babies. When I told Tanya I had you all doing cure surface, oh, okay. No. That's a different world, but right now, I'm being very, very honest with you. When you get into neonates, that's one world, and you get in pediatrics, it's another world. Right now, don't be concerned. Some of you may choose to work with babies or pediatrics, but if you do, you will have probably an extensive orientation. And you will learn what that department uses, because just because they're doing it at children's, it may be a little different at Hurley. So you will learn. Who was I speaking with? I was speaking to a graduate of the program who's working on her bachelor's degree now. I happened to go to a class Thursday night to evaluate an instructor, and she was in the class, so we talked. And she is doing an extensive 3-month, 90 days, she's on her 20th day when I saw her Thursday, an extensive 90-day orientation to work in NICU at one of the hospitals where babies are delivered. So even though she's registered and she's been registered for the past 4 years, they're not cutting her loose till they've orientated her to specifically how that department functions. So you don't get upset. I need to know all of it. You will not. You will not. Okay, just have a general working knowledge of these drugs. There's no way. Doctors don't know it, and so we're not. But what you should know is albuterol. You really should know that. Okay? All right. So any more questions on ultra short acting SABA or LABA? Okay, I want you to turn to page 111 and look at the box 6-2. These are side effects seen with beta agonists, and this is beta 2 agonists, obviously. The number one side effect is palpitations and tachycardia. Where does that come from? Well, most of it comes from anytime you administer beta 2, the number one side effect is beta 1. Okay? That's why we don't administer epinephrine anymore as a beta 2 agonist. Does that make sense? Yes. Okay. Now with albuterol and levoalbuterol, these are not synergistic. These are drugs manufactured synthetically, so they have less of a beta 1 effect. But nevertheless, we still assess the pulse before, during, and after therapy. Anytime you administer a beta 2 agonist, you want a pulse before, during, and after. Okay? And then in that vein, I'm going to give you a rule of thumb. It's not in the book, but I'm telling you now, and I think we'll cover it again in patho. When you're administering a beta 2 agonist, when do you stop a treatment if the heart rate has increased? If the heart rate increases by 20%. Write it down, because I'm going to ask. 20%. If you're administering a beta 2 agonist, and the heart rate increases by 20%, stop the treatment. Not 20 beats. I'm not saying if the heart rate is 95 and it goes up to, what's 90 at 115. That's not what I'm saying, 20%. So let's do this. Let's say the heart rate, we started a treatment and the patient's heart rate is 80, right? Mm-hmm. Take the 80 and multiply it by 0.20. What's 8 times 2? 16. All right, so that's 16. So now, if the patient's heart rate was 80, add the 16 to it. All right, so 96. If the patient's heart rate goes beyond 96, so let's say we started out at 80. and within 3 minutes of the treatment, the patient's heart rate is 100, stop it. Because that's not the choice drug for the patient. We need to notify the physician and say, we can't get through the treatment without the patient's heart rate increasing by 20%. Now, some physicians will say, that's okay. How far did it go? Some physicians will say, okay. But nevertheless, for a rule of thumb, if the heart rate increases by 20%, we should stop the treatment. Got it?
Good.
Not by 20 beats, 20%. So if we have a patient and we start out and their heart rate is 100, and you multiply 100 times 20%, what's the number? 120. So we start out at 100, and within 3 minutes, we assess the patient's pulse, and the pulse is 115. That's okay, because it's still below 20%, right? And it stays maybe 115, 116, it's okay. And then after the treatment, that side effect will subside. But if we start out at 100, and in the middle of the treatment, we assess the heart rate at 130, stop it. Now, you might be in a precarious situation, if you got an asthmatic who's wheezing and the heart rate goes up. We have to judge, is this heart rate going up because we administered this treatment, or is the heart rate going up because the patient is experiencing hypoxemia? This is when you have to know your respiratory care, because remember, you have an asthmatic who's having an acute exacerbation, right? Any patient, if they're experiencing hypoxemia, the first compensatory response is tachycardia.
Right.
We have to take that into consideration. So maybe in that case, we don't want to stop the treatment, but we'll monitor the patient very closely after the treatment to see if the heart rate starts subsiding. Because if we've given the beta-2 agonist to deal with the wheezing, and we're administering oxygen to deal with the low PO2, that should lower the heart rate. Does everybody understand what I'm saying?
Right.
We have a textbook to guide us, but everything is not textbook. It's you and that patient. It's you and that patient. Always patient assessment. Any questions? Got it? Okay, so let's look some more of these side effects. These are common side effects, but what's most important is palpitation and tachycardia. Tremor. Where does the tremor come from? Activation of the sympathetic nervous system. It makes you nervous. It makes you excited. And patients will tell you, I don't want to take this because it makes me nervous. It makes me shake. And you have to explain to them it's a side effect, but doesn't maybe a half an hour, doesn't it stop? Doesn't it subside? Yeah, but every time I see you coming, I get nervous because I know what you're going to give me. Yeah, that's true. And sometimes we really, really have to educate patients, particularly with the MD and DPI, because they'll say, I don't like to take this because every time I take this, it makes me shake. We have to explain to them it's a side effect, but it's important that you take this drug because you need it. Does it make sense? Mm-hmm. That's from the sympathetic nervous system activation. Some people have headaches, some people have insomnia. So you're in the hospital, the doctor has ordered something Q6 hours, and Q6 hours means every 6 hours. And you're working the midnight shift, or you work from 7 p.m. to 7 a.m. And the patient's treatment is due at 1 o'clock in the morning. If a patient is asleep, I know the patient is not wheezing. If a patient is asleep, I know the patient is not in distress. Let them sleep. Let them sleep. Because if you give them that treatment, they may not be able to go back to sleep. Does that make sense? When a patient cannot breathe, a patient cannot talk, a patient cannot sleep because they can't lie down.
a patient cannot eat, a patient can't do anything but focus on breathing when they're in distress. So at 1 o'clock in the morning and you got an asthmatic and they're asleep and you don't hear them wheezing, and when I say don't hear them wheezing, you don't audibly hear them wheezing, you don't need a stethoscope, let them rest. And then if the nurse calls you at 3:30, they're up, well then you got to go get a treatment. And then you can let them know, I didn't wake you up because you were asleep. So I knew that you weren't that short of breath or you weren't having a difficult time because you were asleep and you had on your oxygen, right? That's a problem, and that may be a reason why people don't want to take their beta-2 agonist, is because they say, when I take this drug, I'm frazzled. For some people, not everybody. Perhaps some of you do it, I don't know. But maybe you're going to study late, and for some people that really like coffee, they'll drink coffee at 10 or 11 o'clock at night, and it gives them a boost. This is what a beta-2 agonist will do. Does that make sense? So this is a side effect: insomnia, dizziness, nausea. When I was younger, and I didn't even give you all Bronchosol. But when I was younger, I had to take Bronchosol, and I didn't like it because it made me nauseated, and I would throw up. That was a side effect for me. And look at this word down here, hypo. No, I'm not going to give you that. We'll come back to that. I'll give it to you later. Tolerance to the bronchodilator effect. That means over a period of time, the drug is no longer effective. So those above it, the tremors, the tachycardia, the headache, the insomnia, and look at the increase in blood pressure. Where does that come from? If it's a beta-2 agonist, it doesn't have a alpha effect in it. Where did that come from?
Because of the tachycardia.
Talk to me. Tell me what.
Yeah, because the heart rate increases, and when heart rate increases, the vasoconstriction happens because the blood pumps more.
Very good, because the heart rate increases and the myocontractility force increases. That increases the blood pressure. But after the peak effect of the drug, it will slow down. Okay, and people feel it. They feel their heart pounding. I feel my heart pounding. That's because of the beta-1 effect. And people will tell you, I don't want to take this drug because of the side effects. Okay. So the tremors, palpitation, tachycardia, headache, insomnia, increase in blood pressure, nervousness, dizziness, nausea are very, very common. Very, very common. Very common. Even in our man-made drug or synthetic drugs such as albuterol and levalbuterol, we still have to do a pulse before, during, and after a treatment because beta-1 works along with beta-2. That make sense? Okay. So that's what you need to know. Okay. Now let's turn to Chapter 7, anticholinergic drugs. These are not front door bronchodilators, right? What kind of bronchodilators are they? Back door, very good, meaning they do not work on the sympathetic nervous system. They work on the parasympathetic nervous system, yes? Yes. All right. And you can look at the terms on page 7, I'm sorry, chapter 7, which is page, 119. And what I want to point out with key terms and definition, and I know I went through it, but I'll hit it again. To the right at the bottom, it says muscarinic. See that term? Yes. It's the same as cholinergic. Agent that produces the effect of acetylcholine or agent that mimics acetylcholine. So parasympathomimetic, cholinergic, and muscarinic are synonymous terms, right? Okay. So parasympatholytic anticholinergic. I'm giving you guys time to write. And anti-muscarinic mean the same thing, right? Any questions with that? So your parasympatholytics, or anticholinergic, or anti-muscarinic, are synergistic bronchodilators. Do you all agree? Can I erase this? Did everybody get this? Behind this curtain. Everybody got that? Over there, you got this over here? Okay.
Thank you.
I always question, they put this up, why didn't you put it on one side? You got it right in the middle. But anyway, I'm not complaining. Okay, we know our direct-acting beta-2 agonists, whether it's SABA or LABA, increase 3,5-AMP, right? At cellular level, and then that gives us bronchodilation. Then our anticholinergic, anti-muscarinic, or parasympatho, and that's a mouthful of it. Lytics. I don't know if I spelled that right. No, I didn't. Sympatho. Decrease 3,5-GMP. It was the class of 2010. There was a time they mocked me, and I laughed. And I said, how do you all know that? They said when I used to hit the board, that meant they knew they needed to know it. So, hitting the board, you need to know it. Okay. So anticholinergic, anti-muscarinic, or parasympatholytics don't have anything to do with the sympathetic nervous system. They decrease 3,5-GMP, so they're synergistic. These drugs alone may not necessarily enhance bronchodilation, but along with the LABAs or the SABAs, they will. Yes, ma'am.
So you would never give an how do you say that word?
Muscarinic.
Muscarinic.
You can give it alone. When I say alone, you can administer an anticholinergic, but I know that the patient is also taking a beta-2 agonist. They don't have to be like Respimat together. What you could do is give, if the patient is bad enough, we have done this. 1 hour I've given a beta-2 agonist. The next hour I've given an anticholinergic. The third hour I've given a beta-2 agonist. The fourth hour I've given an anticholinergic till my wheezing breaks.
So we are kind of giving them synergistically, they're just staggered.
Yeah, they're just staggered. Yes. Or you can give them a drug like Respimat that they both come.
Okay, but that wouldn't be the first thing that we go to, right?
No, this is not the first thing you go to. This is for someone probably like COPD.
Okay.
Yeah. All right, here we go. Look at key point on page 120. It says anticholinergic agents given by inhalation offer a second class of bronchodilating effect. It's not the first class, it's the second class, right? So that's why I refer to it as a backdoor bronchodilator. Okay? It says indication for anticholinergic bronchodilators. Ipratropium and tiotropium are indicated as bronchodilation for the maintenance and treating COPD. COPD. These drugs are not necessarily for the asthmatic. COPD. Okay, and then we're going to go through the difference between these two. Including chronic bronchitis and emphysema. Chronic bronchitis and emphysema make up what
COPD.
condition?
COPD.
COPD. Here it is. It says ipratropium is used and may be indicated in some individuals with asthma. That's a person who's got asthma real bad. But just for your, God, I was going to say traditional asthmatic. There's no traditional asthmatic. But for your mast cell degranulation, these drugs are not first choice. Make sense? All right. So what two drugs are we going to use for the asthmatic? Well, actually three drug classification of drugs for the asthmatic. Beta-2 agonists. What else? Steroids. And the third?
Anticoagulants.
Maybe.
Oh,
No. Short act.
you're going to kick yourself in the butts. Oxygen.
Oh, really?
Is oxygen a drug?
Yes.
Yeah.
Okay.
Can you just repeat those three?
Oxygen. Beta-2 agonists. Corticosteroids. Got it? Okay. Oxygen is a drug.
And this is for COPD.
No, that's asthma. That was asthma. All right. So, okay, let's look at table 7.1. Inhale anticholinergic bronchodilator agents on page 120. Ipratropium bromide. Ipratropium bromide. The trade name is Atrovent. Know it. Ipratropium bromide is Atrovent.
What does HFA stand for? Is that the company?
No, HFA means hydrofluoride alkaline. I haven't explained that yet. That's what all of them are. I skipped chapter 3. I'll go back to it. But no, HFA is not the manufacturing company. It means when I see that, I know that it is comes in an MDI.
It's just a propellant, right?
It's a propellant, absolutely. The last one, the CDCs were doing damage to the ozone, so they've changed it. So Atrovent comes in an MDI, and it's about 2 puffs. Most of the time when you see Atrovent, it will be MDI. And depending on where you work, you may see it in a small volume nebulizer solution. And then now with the Atrovent, you also see it in nasal spray. Okay. Let's look at the onset. It's 15 minutes. The peak is 1 to 2 hours, and the duration is 4 to 6. Okay. So you got a COPD patient that's coming in wheezing, and let's say they have been given a beta-2 agonist, or better yet, maybe the physician doesn't want them to have a beta-2 agonist because whatever reason, their heart rate is elevated, whatever. And the doctor says, well, I don't want them to have albuterol. I don't want them to have levoalbuterol. What do you recommend? What you would do is you would recommend the Atrovent. Okay, recommend Atrovent because they're wheezing. And then when we get to, and I'll explain it next, look at the bottom, tiotropium bromide. Now look at the onset. You see the onset for Atrovent is 15 minutes, and the onset for Duonev or Spiriva, particularly Spiriva, is 30 minutes. a little longer, peak hour 1 to 3, but look at the duration, 24 hours. 24 hours. So, most of the time, when the patients come in the hospital, we'll administer the Atrovent, because it's short-acting, and they'll go home on Spiriva. Know that. We will administer the Atrovent as an anticholinergic agent, and they'll go home on the Spiriva. Okay, now the book is not going to tell you this, and it is not such, but just to provide clarity. There's no such thing. I'm just using this to help you understand. Got it? Atrovent is short-acting, and Spiriva is long-acting. So if we have a patient coming in and they're wheezing, we don't want to give them a controller drug such as Spiriva. We want to give them a rescue drug, and these terms are not used, but I'm using them to help you understand. If they need an anticholinergic drug now, Atrovent. If we want to give them an anticholinergic drug to go home, Spiriva. And if I'm not mistaken, the commercial where the elephant sits on the man, he follows the man and sits on his chest, that just tickles me. I think it's for Spiriva. Have you all seen it? Man, I have COPD, and I'm like, yeah, you're just an ad. Because people with COPD don't. I have COPD. Yeah. It tickles me, and the elephant walks around, and he's real slow, and you see the man lie on the couch, and the elephant would just kind of sit on him. It's more like a monkey on his back as opposed to elephant on his chest. But anyway, it's a good commercial. If I'm not mistaken, I think it's for Spiriva. So patients go home. And why? Because Spiriva, it lasts up to 24 hours, so they may only have to take it 1 time a day. They're both anticholinergic. But the difference is Atrovent is short-acting and Spiriva is longer-acting. Okay? And it's used more so in COPD patients. That's the time here is very, very important. Okay. Dual nab. Now, I'm going to the second one. Ipratropium bromide and albuterol. Here they have Combivent. But we're doing away with Combivent as of December. So write in your book, if you choose to, we're going to call it Respimat. That's what you learn. They're doing away with Combivent. Now, why specifically, I don't know. But we're going to call it Respimat. In the hospital, if you have to administer it, it's called dual nab. You see it comes dual nab. It's called small volume nebulizer. I'm sorry. The form is small volume nebulizer. Dual nab. It's ipratropium bromide and albuterol. We talked about drugs being synergistic. See it? For COPD patients. Now, as I was explaining to Catherine, at one time when I was in the hospital in ER, I had to go Q1 hour treatments. 1 hour it would be Bronchosol, which is a beta-2 agonist. The next I would give atropine. The next Bronchosol. The next atropine. We don't have to do that anymore because we now have drugs like dual nab and we can give them together. Okay, and that's what you'll administer in ER, ICU, or wherever it may be, to break those bronchospasms. But again, not saying that it can't be used in an asthmatic, but most times it will be your COPD patients who are in acute exacerbation. And those wheezes got to be broken, and a beta-2 agonist alone is not enough. Okay. Anticholinergic. So, you know, ipratropium bromide is Atrovent, short-acting. Tiotropium bromide, Spiriva, longer-acting. and then a combination of a beta-2 agonist and an anticholinergic is Respimat. And when you administer it as a small volume, in a small volume nebulizer form, it's called DuoNeb. And it makes sense. Duo means what? Two. Two things in a nebulizer. And that drug, those drugs together will have an increase in 3,5-AMP and a decrease in 3,5-GMP. This is complementing that. Right? Mm-hmm. Any questions? Do you still have to assess the heart rate? You bet your sweet bippy. You bet your sweet bippy. Because you're giving 2 drugs that can raise the heart rate now. So you're still going to do your pulse before, during, and after. You're still going to listen to the patient's breath sounds before you give the treatment. Because if you don't listen to them before you give the treatment, you don't have anything to compare after. Right? And you may not always have clear breath sounds afterward, but you have less wheezing or less whatever. Okay? And you always want, if the patient can, you want to see after you've given the treatment if they can have a productive cough. Because now if it's a COPD, we know we're not dealing with mast cell degranulation. We know that. So with a COPD, more than likely, the culprit of the wheezing is excessive secretions. So after the treatment, we've opened the airway with our therapy. We want to see if they can have a productive cough. So in addition to hearing the wheezing, we'll hear rhonchi. Rhonchi, that's secretion sitting in the airway on expiration, right? Mm-hmm. And we want, after they cough, the rhonchi should be cleared or subsided. It may not go away the first treatment, but it should be a little better. Does that make sense? Mm-hmm. Okay, everything we do is all about patient assessment. Any questions on the anticholinergics? Okay, another anticholinergic or parasympatholytic that I want you to know, right on page 120, if you see it to the right, atropine sulfate. At one time, these drugs weren't out. Atropine sulfate is to the right here. Oh. At one time, these drugs, DuoNeb, wasn't out, and I administered atropine. We no longer, as therapists, administer atropine. We don't administer it. But I'm going to tell you what it's administered for. It's still an anticholinergic. Everybody with me? Mm-hmm. All right. We got this patient that comes in the emergency room and they're full-blown cardiac arrest. Yes? Mm-hmm. We're going to do BLS on them. Physician is going to order an AMPA-epi because the cardiac heart rate is zilch, asystole. Okay? Maybe a couple of amps of epinephrine. The doctor doesn't want to administer too much epinephrine, so maybe let's say I'm picking a heart rate. The heart rate gets up to 35. When the heart rate gets up to 35, and I'm just picking a number, then the physician or we will recommend atropine. It is an anticholinergic drug, but when is it used? When a patient is experiencing bradycardia. Write it down. When a patient is experiencing bradycardia. Generally a heart rate between 30 and 55. We don't recommend atropine. We don't recommend epinephrine. We recommend atropine. And you will be asked this on your boards. But you'll know it because I'm going to ask you a gazillion times before you get to the boards. So full-blown cardiac arrest, epinephrine, yes?
Yes.
Patient is experiencing bradycardia, atropine. What is its classification? Parasympatholytic, anticholinergic. Do we as therapists administer it? No, but we know what it is and when to use it. Bradycardia. And what will it do? Increase the heart rate. Make sense? That's why if we administer dual neb, we still have to assess the pulse before, during, and after. Because if this decreases 3.5 AMP, we know this causes bronchodilation, but we also know beta 1 is there and it's increasing the heart rate as well. Make sense? Okay, so atropine is a drug that we as therapists no longer use, but we need to know that it's indicated for a patient who is experiencing bradycardia. And we use, or we will recommend epinephrine for a patient with full-blown cardiac arrest. Right? All right. Any questions? We're chugging. I got to move because Miss Pope wasn't happy with me yesterday. We don't have to because now we have Atrovent and Spiriva. Yeah, man-made drugs. Woohoo! Any questions? And see, we can chug along through the drugs now because you know what these mean. Right? All right. Okay, let's look on page 121, the key point. Anticholinergic bronchodilators are specifically parasympatholytic, that is, anti-muscarinic agents, blocking the effect of acetylcholine at the cholinergic muscarinic receptors on the bronchial smooth muscle, and you know that. That's this. So we call them backdoor bronchodilators. And that's simply for us to know that they don't have a direct effect on the sympathetic nervous system. And because we know cardiopulmonary, we know when epinephrine should be administered, and we know when anticholinergic atropine should be administered. And atropine is for bradycardia, epinephrine is for asystole. Got it?
Got it.
Good registry questions. There's going to be a lot of drugs you all learn we don't administer, but you need to know when they need to be. We're going to get through insulin as well. All right. Yes?
You used a synonymous word for cardiac arrest. What's that called?
Asystole. No heart rate. Asystole, full-blown cardiopulmonary arrest. Okay, and to further support what you were asking, Heather, turn to page 122, key point. The only approved anticholinergic agent for inhalation as an aerosol at this time is ipratropium bromide, Atrovent, which is available in an MDI and a small volume nebulizer solution and an intranasal spray. Okay, Spiriva is available in DPI. I answered your question. Okay, there you go. All right. So we don't have to use the atropine anymore because the FDA have approved these drugs. Okay? So Spiriva is a DPI. And Atrovent is what? An MDI. And you may find some patients that use the nasal spray. You know, they're only giving it to new diabetics, but they have a nasal spray now for diabetics where they don't have to take injections anymore. But they're only giving it to newly diagnosed patients with diabetes, not the older patients. And when I say older, I don't mean in age. Patients who've been diagnosed with diabetes 5 and 10 years ago are not candidates for it. Yeah, so they're coming up with newer drugs. Yes.
Why would they, just out of curiosity, why wouldn't they be a candidate for that?
You know, I don't know. I don't know. It could be because they've been taking the injection and they probably did studies. I don't really know, but it could be because they've been taking the injections. They don't tolerate the nasal spray, whereas new patients, brand new diabetics, if that's what they start on, they'll probably tolerate it and it's more effective in their body. But the real reason, I'm not sure. I need to ask my physician when I go see her.
Thank you.
Okay, turn to page 125. I just want to reinforce. Under the key point to the right, it says the anticholinergic agents, ipratropium, which is which is Atrovent, and tiotropium, which is the Spiriva, are indicated for the treatment of airflow obstruction in COPD. So these are the choice drugs for our COPDers, because they may not necessarily benefit just from a beta-2 agonist, right? Because we know that whatever their problem is going to be there forever and a day. It's irreversible. And we can't leave them on LABAs. And beta-2, short-acting beta-2 agonists may not get the job done. So some may be on Atrovent, and some may be on Spiriva. Don't be surprised if you have some that are on both. It just depends. So Spiriva, again, is DPI. Atrovent is MDI. And Respimat is called dual NEB, and it's SVN. You probably won't have either one of these drugs used in pediatrics. Children don't have COPD. Yes.
Is dual NAB only given in the small volume?
When we administer, yes.
Okay.
Yes. It's called dual NAB. Yeah. If they go home in the MDI, it's Respimat. If we administer, well, it's still the same drug.
Okay.
But if we administer it, the trade name is dual NAB. And if they go home on it, it's Respimat.
Okay.
Make sense? So dual NAB is liquid, and Respimat is MDI. Any questions? Okay. Yes.
Patient go home on Symbicort as well by then corticosteroid.
Depends. It could. It could, or it could be an asthmatic. Could. I'm not going to tell you no. Mm-hmm. It really depends on where they are in their maintenance of their disease. Okay, let's look at page 124, table 7-2. I just want to go through some things. Cholinergic effect is the parasympathetic nervous system, right? And the anticholinergic effect is what? Parasympatholytic. So I just want to compare a few things. Okay, it says decreased heart rate. That's the 10th cranial nerve, right? And that maintains our heart rate between 60 and 100 beats per minute, yes?
Yes.
Okay, that's what that is. That's the parasympathetic nervous system. But if for whatever reason a cholinergic drug is administered, it would decrease the heart rate a little bit more. All right? Next, if you look at the anticholinergic effect, it's going to increase the heart rate. And that drug we talked about was atropine, right? And we administer it, or we don't administer it, we recommend its recommendation for bradycardia. There it is. Now, if you look at the anticholinergic drugs, under drying of the upper airway, the parasympathetic nervous system is responsible for homeostasis and responsible for us and our, is responsible for part of our airway being moistened. The Disadvantage of these drugs, it dries out the airway. And so even with COPD patients, let's look at this. They're taking this drug to facilitate bronchodilation, and they're taking this drug to facilitate them expectorating or coughing up excessive secretions, right? One of the things we need to monitor is make sure that this drug doesn't dry up the secretions and cause mucus plugging. So we have to make sure, not just us, nursing as well, nutritionists, we have to make sure that COPD patients adequately hydrate, because they'll get mucus plugs using this drug. Does that make sense to you guys? Mm-hmm. And what will a mucus plug do in the airway? Block it.
Block.
It's called resorption atelectasis. Resorption atelectasis. I'll write it down. Resorption. Resorption atelectasis. What is that caused by? That's atelectasis caused by mucus plugs. Fur balls. That's what I call them. So we want to make sure to tell our patients that are using this anticholinergic drugs that they adequately hydrate. Got it? Any questions? We're concerned about mucus plugs. That's a side effect of it. I don't like taking this drug. It dries my mouth out. And then if you look at the last one, you see the cholinergic effect causes bronchoconstriction, yeah, right? That's an increase in 3,5-GMP. And then if you look at the anticholinergic effect, it says inhibition of constriction. You see, it doesn't say bronchodilation, does it? Because it's not a true bronchodilator. We just call it a backdoor bronchodilator, but it's not a true bronchodilator. So it says inhibition. See the difference? Okay. All right, let's turn to page 131. Okay, before treatment, this says assess effectiveness of drug therapy based on the indication for the aerosol agent. Presence of reversible airflow resulting from primary bronchospasm obstruction secondary to an inflammatory response, either acute or chronic. Monitor peak flow meters, portal spirometry, and lab reports, pulmonary function testing. So just like I mentioned with the beta-2 agonists for some asthmatics, how we know whether these drugs are effective for COPD patients, they have to come in and get a PFT test done. Okay, PFTs, pulmonary function testing. And remember, I told you, you now know, even though we haven't gotten the pathophysiology, and I'm not expecting you to know pathophysiology, emphysema and chronic bronchitis make up COPD, right? Yeah. Okay. So remember I said it's stage 1, stage 2, stage 3, and stage 4? A pulmonologist makes that determination based on a PFT. So a pulmonologist can also make the call whether these drugs are effective based on PFT. And it's not from 1 week to 1 week. It may be from 1 month to 3 months. And the patient will initially come in and do a pulmonary function test. Okay, we have a baseline. Patient may go home for the next 2 or 3 months, I'll say 3 months, and then come back in 3 months, and they've been on a medication for 3 months. And so the Pulmonologists will know whether the drug has been effective based on the PFT results. Okay? Asthmatic patients and COPD patients have a problem exhaling. So when we look at PFT results, we want to see what they're exhaling. Okay? Here we go. Just write it down and I'll explain it. Can you see over there? FVC, FEV1, FEV2, FEV3, and PEFR. Okay? FVC is forced vital capacity. FEV is forced expiratory volume in 1 second. 1 means 1 second. So 2 would mean what? 2 seconds. Forced expiratory volume. And FEV3 would be forced expiratory volume in 3 seconds. I'll give you time to write that. Can you see it, Ebony? Everybody got 1, 2, and 3? And then PEFR, peak, P-E-A-K. What's the E? Expiratory flow rate. Why expiratory? Because obstructive disease patients, what? Finish the sentence. Have trouble exhaling. So physician will look at these values. Okay? All right. So what I want everybody, put their ink pens down and follow my instructions. Suck in a real deep breath, hold it. Now blow it out fast and deep. Blow it out, blow it out, blow it out, blow it out. Keep blowing, keep blowing, keep blowing, keep blowing, keep blowing. Ah! That's a forced vital capacity. Now, do you think a COPD patient could do like you did?
No.
Absolutely not. So this value will be decreased. Forced vital capacity. Suck in a real deep breath and blow it out fast and hard as you can.
These are all pulmonary function.
These are pulmonary function results, yes. This is called spirometry.
Excuse me, Ms. Miller. What
Yes,
is
sir.
PEFR is peak expiratory?
Flow rate.
Thank you.
F-L-O-W-R-A-T-E. And this is in meter. This is in seconds. This is in seconds. This is in seconds. And this peak expiratory flow rate is in liters per minute. Okay. In cardiopulmonary A and P, you'll get a little bit more. Now, in 1, 2, 3, of this forced vital capacity, everybody with me? We sucked in a deep breath, we blew it out. What this is, how much of this forced vital capacity did the patient exhale in 1 second? How much did the patient exhale in 2 seconds? And how much did the patient exhale in 3 seconds? And in COPD and asthma, those values are decreased because an obstructive disease means they have a problem exhaling. So we're looking for all of these values to be decreased in obstructive disease.
So if it wasn't an asthma or COPD patient, it would be increased?
Oh, they would be normal. If you don't have asthma, if you don't have COPD, it would be normal. And I didn't go into details, but PFTs are based off of 5 things. I'm not expecting you to know it for pharmacology. I'm going to tell you, but you don't have to write it down. Age, height, weight, race, and sex. That's what PFTs are based off on. And so if you're a therapist and you're doing pulmonary function testing, you would get the patient's age, their weight, their height, their race, and sex. And the PFT is all computerized, so it will predict what normal is. And then we take what they actually do and compare it to what predictions are. And so for the asthmatic and the COPD patients, these values are going to be decreased because they can't get the air out. Does that make sense? All right. So these values are going to be decreased. Even if after 2 or 3 months the patient comes back in and the medication has been effective, we'll see these results improve, but they still are not going to be normal. Got that? All right. I want you just to know with arrows. If I give you these PFT values and I say a patient is COPD or asthma, what would these values be? Normal, increase, or decrease? And you're going to tell me decrease because they have an obstructive disease, they have a problem exhaling, and all of these values are assessing how well they exhale. FEV1 in 1 second, how much of the forced vital capacity were they able to exhale in 1 minute? How much were they able to exhale in 2 seconds, and how much were they able to exhale in 3 seconds? Make sense? Have you all gotten the IE ratio yet?
A little bit.
Okay. A little bit IE ratio. What's normal IE ratio?
1 to 2.
1 to 2. Okay. So if normal IE ratio is 1 to 2, that means 1 part of your breath is inspiration, 2 parts is expiration, right? Well, guess what? If you got somebody with COPD, they may have an IE ratio 1 to 6, 1 to 7. Why? Because they can't exhale. It's going to take them longer to exhale. And they will never exhale at all because they have air trapping. And that air is full of what? CO2. God, you all are getting it. Any questions? Everything we do is tied to something else. So here we have pharmacology tied into PFTs. And now you understand if a patient has CO2, if a patient is a CO2 retainer, they can't exhale at all. So that stale air that's still stuck in the lungs called air trapping is full of CO2, and this is why these values will be decreased because they can't get the air out. Make sense? Okay. So the effectiveness of these drugs is based on PFT. And this one down here, peak expiratory flow rate. I don't know if Ms. Pope has gotten to it, but I see it on the desk. Has she gotten to this in lab yet? She will. This is a peak expiratory flow rate. This is something that we give asthmatics, and also you can do it on pulmonary function testing. But for the asthmatic to go home, we give them based on those 5 things that I gave you. We give them what's normal. And we say, this is green light. If you are in the green light area, see here's a green, yellow, and red light. I'm saying lights, but here they are. This is how you teach the children, because I taught Paulette using lights, stop signs. Green is fine. So if you're above this, just use your control medication and use it every day. You're good. If you're yellow, that means something's going on in your airway, so you need to take this too. Got it? If you do your peak expiratory flow rate and it's below the red line, immediately go to the hospital. And we as therapists educate patients and their families how to use peak flow. So this is called bedside peak flow meter, and you should have one in your lab kit.
Yeah.
And this is just a part of pulmonary function testing where we can teach the patients to assess their own expiratory flow rates. They don't understand it in detail like we do, but they know what the red indicates, what the yellow indicates, and what the green indicates. Green, the light is green, go, you're good. Keep doing what you're doing. Yellow, caution, right? Maybe you need to add something else, and they will have instructions for that. But if your value falls in the red zone or below the red line, go to the hospital immediately. And when they come to the hospital, that's when we'll see them in what we call an acute exacerbation. And we have to get busy. Yes?
No, but we don't perform the pulmonary function.
Yes, we do. Respiratory therapists perform pulmonary function testing. No, pulmonologist is just a physician interpreting it. We do the PFTs. Yes, ma'am. Yes, ma'am. We do the PFTs. We can interpret a PFT, we just can't call it diagnosis. Yeah. Any questions? Okay. Okay, so we've gone through the anticholinergics. Any questions? All right. Look under drug treatment and short term. Assess patient's subjective reaction to treatment for any I'm still on page 131. Assess patient's subjective reaction to treatment for any change, positive, negative, in breathing effort or pattern. Assess arterial blood gases or pulse ox as needed for acute stages with COPD or asthma. To monitor changes in ventilation and gas exchange oxygenation. You should understand what that is now. We're going to look at the PCO2 for ventilation. We're going to look at a PO2 for oxygenation. We're going to listen to the patient and ask them, how do you feel? Are there any changes? Are you breathing better? Right? We cannot ignore patient assessment. And then long-term, monitor pulmonary function testing, capacities and flows. This is the first part of PFT. It has to be monitored. We as therapists do it. And we know what the values mean. Yes.
If a patient came in an acute,
you cannot do this.
You can't do that.
No, ma'am. A patient in distress cannot do a PFT. We have to get them stabilized. Then do this.
But you wouldn't do that. That's not something you would do in the hospital. That's something that they would go to maybe a place for?
They could do it in the hospital. Okay. PFT labs are in the hospital.
Okay.
But when they're in acute exacerbation, you can't do it. You can't do it. You got to get them stabilized first. And then maybe their first PFT will be before they go home.
Okay. So they can see the initial values, and then they've already been on the, and then we put them on the drugs, whatever they may be.
And then they come back 2-3 months later to see if that drug has been effective. And we want to see some improvement, but again, even when we see improvement, it'll never be normal. Because any damage done when COPD is done. And that's why we have stage 1, stage 2, stage 3, stage 4. Make sense? All right. All right. You all wanted respiratory care. This is respiratory care. We do PFTs. We do diagnostic studies. We do PFTs. We do blood gases. We don't do chest x-rays, but we know how to interpret chest x-rays. We do know how. We have to know how. It's part of our job. It's part of our responsibility to understand. Okay? So this is the beginning, and so what I've done is tied in pharmacology into PFTs. It's no good to know pharmacology and don't know what to do with it. And we can't assume just because we give a patient a treatment and they completely cooperate, everything is fine. We have to assess the patient. And how will we know? Have to give them some time. PFT. They got to come back and they have to have a PFT done. Now you may choose not to work in PFTs, but you have to know PFTs to be registered. I loved it when I did it. I loved it.
So that's all you do all day long then, is just determine?
So you do day blood gases and do PFTs. And if you have a patient who does not speak English, you still have to get him to do the PFT. Yep. Okay, so we've gotten through bronchodilators and we've gotten through anticholinergics. I'm going to read these.